Hey guys, so I'm here today with Ben and Glenn. I've chatted to these guys before, and since we've been talking, obviously hip is something that's quite in vogue at the moment. You've got lots of people talking about FAI, there's lots of people talking about hip arthroscopy. Been a few updates in the last couple of years since I've spoken to them both, and these guys have been travelling around the world doing loads of various different courses in running and hips. Today we're going to talk about the hip, and so it'd be interesting to get their feedback and their ideas on the new relevant and up-to-date information, really based on what we went through last time. So I guess the first thing to Ben and Glenn, or particularly Ben, is what the key subjective questions are really that are relevant for hip examination in your view.
Yeah, I think like with any area, the subjective is the key. So it sort of set the scene on what you're going to choose on your objective test. So we can sort of put that into two groups. One is looking into their sort of history. So based from the history, what we look for mainly is the history of childhood hip diseases. So that's something which I routinely ask with my patients now is, have you had any dysplastic hips, Perthes, or any hip diseases? Most patients might not remember that, so it's asking things like, do you remember wearing braces when you're young? And that is something usually, within the age of 4 or 8. So that is important because many of these patients will come back 20-25 years later with potential osteoarthritis. So the past history is really important, and obviously any trauma, so things like long bone fractures, skiing accidents, any sort of fractures around the femur, because post-traumatic osteoarthritis can happen across any joints. And the big one is also how active they were during the teenage years. So that's a very crucial point. So I usually ask between the age of 8 and 18, how was your activity levels? Were you doing a lot of sports? Because for the last year or two, we got evidence showing that the structure of the femur is dependent on your activity levels during your growing years. So pretty much the morphology of your femur is set by the time you're 16 or 17. So those sort of things. So people might say, I used to play 6 or 7 times, playing for 2 clubs. I was playing basketball, hockey. So a lot of rotational activity, more likely to develop into hip impingement morphology. Later in life. So it's unlikely to see somebody who has not done a lot of sports coming with hip impingement. So you need to have that history of loading, and especially before your growth plates close, that's quite crucial as well. So activity levels before, during your growing years. And the key symptoms, like anything else, is your irritability, your night pain, and the big ones for hip is limping history. Many young patients don't necessarily tell you about limping, so during flare-up they have limping as well. And we talk about the pain, again it's being specific. Is it groin? Is it lateral hip? Is it coming from your back? So the location of pain is important. Obviously any pins and needles and numbness, which could potentially mean come from the lumbar spine, and also painful clicking, catching or locking. So those are very important ones to look into. So a lot of dancers and hypermobile populations have sort of clicking, but they are not painful. So it's asking, is that linked with pain? Does it feel like locking? And even some hypermobile population will complain of like subjective feeling of giving away. So things like, does it feel like it's going to pop out? So those sort of is the key ones to ask for. And also with female patient especially, is asking a little bit of history on the gynecological symptoms. So things like, we know nearly 90% of patients with the labral tear, females, complain of pain during sex. So things like, do they have more hip groin pain during sex, heavy periods, or your pain fluctuate? So generally, if your pain is cyclical, if it change during periods, then it's not likely to be mechanical. So link up with women's health physio, things like that. And pretty much the patient group we treat, me and Glenn, are sort of that 45 below. So they're generally quite an active population. So a detailed history on what are they actually doing. So if they're going to the gym, what brings on the pain? Is it cycling? Is it your squatting? Is it your rowing? Or in the weekends, what mostly we find, it's a 2 activity which aggravates them, is a deep flexion and loaded rotation is usually the triggers. So again, taking a big history. Or we get the other end, which is the hypermobile population, where they're doing a lot of stretching, yoga, sort of end range loading as well. So that sort of loading profile will give us an idea about what is the key triggers, which will give us an idea. So those are, obviously we'll be spending around 45 minutes to an hour. We're quite lucky that we spend an hour on our hip patients. So I would say at least 60 to 70% of the time goes through the subjective. At the end of the subjective history, we want to really have an idea on these 3 questions. Have I ruled out any red flags? is it from the hip or is it outside the hip? Or the third question is it a referred pain? So at least you should have an idea before you touch the patient, rather than jumping into special tests and things like that. Hopefully that gives a bit of an idea there.
Yeah, definitely. So then jumping on, sort of moving on to the objective type testing. So what's the sorts of things with objective testing? How are you approaching that for the examination of an adult hip?
Well, it is a complex area. People struggle with it. I think Ben hit the nail on the head there when he said that the majority of our work is done in the subjective. So when we move to the objective phase, we've already got a good working diagnosis as to what we believe is going on. The big thing I think people miss is a structure. So you have to have a structured approach. We know that 60 to 70% of the time there can be several pathologies going on at once. So you have to have a good, valid way of screening for that, to make sure that you don't just jump on whatever your bias may be, So it's good to have ways of screening between the lumbar spine, sacroiliac joint, hip, without having to do full assessments of each of those joints, and then obviously doing a full assessment if that is indicated by the differentiation tests that you do. And then after that, when you get to the actual hip joint itself, we use a layered approach. We use a layering method. So start off looking at them walk to gait, their movements, then moving into the contractile layer, so looking at the soft tissues around there, testing the muscles, then moving more into the inert structures, so looking at the labrum, the ligamentum teres, and then finally coming to the joint and doing the joint testing. I think a lot of, certainly when I did my my postgraduate training, to confirm the hip joint was the source of symptoms, you would almost kind of jump on that and do a quadrant test and kind of scoop around the joint and see if it was sore. The issue is with these kind of clients is that that will always be sore. They're very irritable, and by doing that you'll often flare them up for several days and cloud the whole assessment. So it's having a good structured approach. Make sure you don't miss if it is a lumbar component, if there is a SIJ component, but also making sure that you get the information out of the assessment that you need without stirring up significant symptoms straight away.
I think that is a difficult thing to, with the hip, like you just said there, and it's something I've definitely been taught, is the quadrant test to rule out the hip joint. Basically, using that as it's quite a valid test to actually rule out that there's something not pathological going on inside the actual hip joint itself, or intra-articularly. And I think that approach sounds really good, because you've got those different layers, and I think that's differentiating between those things is really tough, like you say, at times. And so is that something that's kind of changed in the last couple of years for you guys in terms of course, or how has your course kind of changed in the last few years, and what would people, are those the sorts of things that people are learning on the course, that kind of layered approach, that sort of thing?
I think it's fair to say most people find the layered approach new, and certainly the depth that we go into in each layer. So people will think, we do some functional movement screening, but I don't think they look at it in the same depth that we go through on the course. Most people, and like I say, myself included in this, before we started specialising in this area, would jump onto the arthrogenic tests a little bit sooner, or they might spend a large part of their initial assessments going through lumbar testing in full, rather than having some quite efficient ways to rule that in or out and see if it needs further testing. Our course has developed a lot more in other ways, so looking more at post-op protocols and things like that, different rehab strategies that we use, different ways of measuring muscle using handheld dynamometers, all that kind of stuff. So it's developed, but the layering approach has been there since day one, actually.
And we've sort of found that quite an easy way to start with a complex patient. And one thing which we've added in the last year is a lot more focus on just like the groin, the gluteal region has also come up with a lot more research. So the things we've included is things like deep gluteal syndrome, proximal hamstring tendinopathy, ischiofemoral impingement. So again, like historically 5-10 years back, everything was blamed on piriformis. Now we know that there's more complex structures there. And also we looked into having more structure with post-op, and also we've got more trials coming up. So we find the rehab with the hip impingement is more systematic, and we go through in 4 stages in detail, right from the couch to return to play, back on the sports as well. So it's a work in progress. There's been more than at least 1,000 articles published in the last 3-4 years. So it's quite hard for many therapists to be on top of it. So what we've done on our course is just to pick up the key. Me and Glenn, we're full-time clinicians, so we are looking into more clinical application of that. So what you'll be getting is more like the direct application of current research in a structured way, and also giving that sort of key pointers. What are the key pointers looking for? And many patients, therapists are surprised when they hear about conditions like ligament teres, ischiofemoral impingement. So there are a lot more. It's a lot of people have a very simplistic view of just osteoarthritis or hip impingement. There's more in hip and groin. So dysplastic hips, all those sort of stuff. So we try to cover the whole spectrum.
And things like ligamentum teres and things of that nature, are they things that you have tests for to differentiate between that and other hip pathologies? I think that's quite a hard thing to look for often with patients.
Yeah, I think we always keep it in the context that it's rare, so we focus on the more common pathologies that people will come across in 90% of their caseload, which is impingement, arthritis, early onset arthritis, dysplasia. Yeah, so we do mainly focus on that, but you do need to be aware of ischiofemoral impingement, ligamentum teres injuries, things like that. So yeah, we do show ways to test for that, and obviously reinforcing the fact that they normally come in conjunction with something else as well. So you need to make sure you're addressing other areas that you're going to see more commonly also.
Okay, cool. And what are your guys' thoughts on why hip isn't more in vogue at the moment, but a lot more people are presenting with hip complaints. So why is it, do you think, that there are so many more this increase in hip complaints in the UK, do you think?
I think there's a few reasons. I mean, diagnosis. Yeah, so that the diagnosis is on people's radars more. I think the days are going now where it's taking people 3 to 5 years and 4 or 5 therapists to get a diagnosis. So I think it's been recognised earlier. The techniques that we use for imaging have got better. Whether that's debatable, whether it's showing things that might not be relevant as well. You're getting a lot of if you scan in more depth and show more detail, you're going to pick up more stuff. I think people are training much older in life now, so if you get one of the kind of clients that I see a lot of is guys that have played a lot of football or rugby when they're young, and now they're trying to do endurance events or marathon events when they're older, or trying to go back to playing rugby and football in their kind of late 30s, 40s, 50s, which wasn't the case years ago, and problems are developing as a result of that. I think there's a lot more evidence coming out around these developments of CAMs, for example, that are happening when you're specialising in a rotational sport from a young age, and I think we're going to see just more and more around that area as well. So it's been identified easier, it's been diagnosed more quickly, and people are training later in life.
Cool. And what are the hip pathologies that are particularly covered in? You've mentioned some already, obviously, but what are the ones that you generally focus on in your courses, and what are the ones that you think are important?
Yeah, so I think once we get a good grounding with the subjective and also with the layering concept, we sort of keep it simple. We put that into, if you talk about the anterior hip and groin, put that into 2 groups. So look into articular pathology. So generally age is a good guide here. If you're seeing somebody after the age of 40, 45, most likely to be early onset OA, because the hip pathologies, young hip pathologies usually happen around the age of like 18 to 40. You don't really see hip impingement as a first time occurrence in a 55-year-old male patient. So those things usually become symptomatic when you're young. So when you talk about the big 3, which we like to call, is early osteoarthritis, hip impingement. Again, there are 6 types of hip impingements which will go through CAM, mixed type, ischiofemoral. There are many more subtle variations. And another big group, which happens mostly in the female, is the dysplastic hips, so which can be associated with hypermobility or on its own. So a lot of my patients, and even Glenn would say, when they come with the diagnosis of hip impingement, and actually they are not hip impingement patient, they're dysplastic hips. And the way you manage a dysplastic hips is totally different. A lot of strategies which you use for a hip impingement, in fact, could make it worse in a dysplastic patient. So it's knowing the difference between these 3. And then the key point which always makes it more difficult is nearly 70% of them will also have an extra articular component. So it's very rare that a patient with hip impingement is just going to walk in with just groin pain. They'll have a bit of back pain. They'll have some adductor tightness. So the big 4 in your soft tissue are your adductor related groin pain, more common in men, then the hip flexors, then your proximal hamstrings, then your gluteal region as well. So that's pretty much the big 7 in the front. And then going in the back, that's a different ball game, so you've got different layers, the deep gluteal syndrome, ischiofemoral, proximal hamstring. So we spend half a day just on that region. So in total, you're talking about at least 15 to 20 pathologies here. And the most common are the 7, the 3 plus 4. but you need to if you're not aware of it, then you'll put them in the boxes.
Yeah.
So most people know about osteoarthritis and hip impingement. They'll put everyone in that two groups. So it's knowing there are more variety. I would say it's as complex, if not more complex, in the shoulder in the variety of options you see. So there's a lot of pathologies you need to be aware of. But in reality, you might only see 6 or 7 of those. So we try to cover all the key pathologies on the course.
And you mentioned there that dysplastic hips and impingement, you're going to treat them differently in terms of management. So in what way would you do that?
So I think the etiology is always useful to know about the etiology. So hip impingement, is a motion control process where it needs that repeated cycles of loading in deep flexion rotation. Whereas dysplastic hips is a failure of structural failure where it doesn't have enough coverage on that. So the way a dysplastic hip usually compensate is they're usually very common for the labrum to become thickened, and they'll have pain more into end range extension and external rotation, which is not the case in a hip impingement. So the key differences clinically you can find is, it's always difficult to say 100% unless you have an X-ray.
Sure.
But there are a few key pointers. One is usually with the dysplastic hips there is no range of motion restrictions. So if you check the range, they'll usually have more, or same. They'll have an internal rotation of 30 degrees, external rotation of 60 degrees. So range of motion is never a problem. They have adequate range, and usually the end range, just like the capsule of the shoulder, it's sort of weak in end range extension and external rotation. So you'll find that it's painful when they go into that range. Where in fact those movements are less painful for a hip impingement patient. They like that opening up the hip. Whereas if you open it up too much in a hip impingement, in a dysplastic hip, it gets more painful as well. And also you find a lot of dysplastic hips, the secondary stabilizers, they come with hip flexor pain or with glute med pain, because those two muscles overact because of the lack of static stability as well. And another last point which is the difference is the number one symptom we find with hip impingement usually is sitting. Sitting is the most common pain. When they sit for long periods, they're driving, they get pain. And that's not the case with most of the early dysplastic. Usually it's weight bearing, so walking, running, all the impact sports. So there's a lot of variation. So we treat them quite differently based on the presentation and the profile. But the reason I feel they get missed, they put in the same group, is both of them happen in the same age group. Sort of 20 to 30s. Both of them usually very active, slim, going to the gym, and both of them usually have groin pain. And the test, for example, if you do a FAD test and a Faber test, it's positive in both. So it's easy to sort of put them into as a hip impingement. So I was going
to say, would the main clinical diagnosis then be made via imaging?
Yes, So simple, like an X-ray will tell us. But the X-ray, suppose you get a yoga teacher who is hypermobile, so that's her pain is because of the hypermobility or what we call the laxity. So it's impossible to, in my opinion, to differentiate between a dysplastic hip and a hypermobile patient without an X-ray. All you can say is the patient has got a lax hip. So the differentiation, but you can definitely clinically differentiate. So when we teach in our courses, we clinically, suppose you're working as a lone worker, you don't have access to imaging. At the end of your subjective and objective, you should put your patient in. First is to make sure, is it articular or extra-articular, and then is it OA, is it impingement, or is it instability. So those are the 3 groups you can put in. So we keep it quite simple there. So generally we can't say, oh, it's pincer, it's mixed, things like that. You can say it's OA, it's impingement, it's instability. And I think that's more than adequate, I think, to start treating.
Absolutely.
You don't necessarily need an X-ray to start with that. What would you say on that, Glenn?
Yeah, absolutely. I think we can't diagnose without imaging. There's no test that we do that can clinically diagnose as Ben said, even an impingement or a labral tear or a dysplastic hip. But you can build up that clinical picture with your clinical reasoning and with your questioning and with your objective tests. And then if you need to confirm that, then a simple X-ray is enough.
And one of the key goals of our course is to, when you come back and see a patient on Monday morning, can you differentiate between these 3? Can you pick up an OA, impingement and instability patient? That is a big start, because most of them, they lump together. And they all happen at the same age group as well. So we're seeing people in the 30s coming with early hip OA as well. So we can't really go with your gut feeling. And an X-ray nowadays in a modern age, an X-ray shouldn't be a massive problem. Most GPs will not be happy with an MRI, but you can always request for an X-ray to rule out osteoarthritis.
Cool. And I think going on the back of that, it's quite interesting because it is obviously a complex area. So, what is it, do you think, about the hip that people do struggle, with the examination and things that people find clinically challenging, do you think?
Well, I think you can have a lot of regions that will cause pain there. So you can have a lot of MSK conditions, gynecological problems, abdominal issues that can present with groin pain. When you look at mechanical and musculoskeletal areas as well, you've got your lumbar spine, your SIJ, it's part of the lumbar pelvic hip complex. So differentiating through that is quite challenging. I think when you add into the mix, as Ben mentioned, that almost 70% of the time there's more than one pathology going on as well. There's more than one factor. It becomes even more confusing again, doesn't it? And if you do the traditional approach of doing a quick movement assessment and going in and doing the hip test, it's going to be positive for pretty much every hip condition that you come across. So I think we make it sound quite simple when we talk about these classifications and these layering concept methods that we go through, but to actually come to that way of assessing, it's not been a simple process, is it? And it takes time. So I can totally understand. I think even when you look at the literature, the terminology can be quite confusing, and lots of similar terminologies for the same condition. So when you try and do your own research and read around, it's quite difficult to come to exact conclusions from that as well. So I think it's certainly lacking when I was taught the structured approach, the layering approach, classifying things, looking at their age, looking at their activity levels, and all of those things build up the clinical picture and the presentation and help you come to a diagnosis. And then once you've got that diagnosis, then there's the added challenge of, so how do you address it? If you're going to look at an impingement patient, for example, conservatively, how do you start with that? How do you manage their load? Most of these clients are athletic, they're sporting, they're doing, or they're at least trying to do some form of sport. Do you stop them? How long do you stop them for? Do you send them on for surgical review? It's difficult decisions to be made, and I think unless you've had some training in that area, it's not something that you can just come across and do.
Yeah, a couple of things I would add is, unlike other joints, it's quite a deep joint, so you can't really rely on palpation. So you can't really say with the hip, because there's a lot of structure in the front of the hip. So like the psoas palpation, as we know, you're going through so many layers. So it can't be very accurate that it's actually coming from the hip as well. And the second reason is a variability. For example, like you can have a patient with hip impingement. One could be a male who comes with a groin pain. A female runner with a hip impingement will just come with a lateral hip pain, no groin pain at all. So we have a couple of patients who come to a Harley Street clinic who have been diagnosed with gluteomedial tendinopathy. Just lateral hip pain for 14 months, not improving, but actually the underlying cause was the hip impingement. So when you have hip pathology, it can refer into 5 places: groin, lateral hip, anterior thigh, posterior hip, back. So it's knowing the variability of presentation. So if you ask me what's the typical presentation of hip impingement, I would not say there's a typical presentation. Majority will have groin pain, 80 to 90%, but there will be groups which won't have. So it's having that open mind and saying like there's a lot more variability of the presentation, and I think that's where a new grad or somebody who's struggles is the pattern recognition. So what we try to do on our courses is give you the common pattern recognition. So we have 3 models. So for hip impingement, we tell you these are the 3 models you will see patients being presented. For a dysplastic patient, we know the models. There are two types of patients. So even like, because we see only hips on our clinics, and when a patient walks in, we can know, suppose a middle-aged yoga teacher comes in, so I immediately put him in a box. It could be a pincer type hip impingement, or it could be a dysplastic. So I'm already having the answers here, and that can only come by seeing that repeatedly. So if somebody gives you that sort of shortcuts and giving that sort of boxes, then you don't have to go through suppose I had a referral from a female patient who said it's got sports hernia, and that you don't really get a sports hernia in a female population unless she's playing for England or Arsenal or something like that. So again, it's knowing those things. What happens, what's common, what happens in that age group, and that is where we'll give you that sort of shortcuts to enable you to fast track. Young male footballer, it's going to be adductor related groin pain. It's pretty straightforward. Playing hockey, football. So that they come with inner thigh pain. You're not going to think of more complex things there. So it's having that sort of boxes, although they are not like set in stone, but it's still useful to make that sort of judgment there.
And you mentioned having that open mind as at the same time as that, so having those patterns, but also having that open mind. And I think that's relevant when you get on to talking about things like red flags, and so other conditions, you mentioned other conditions around there. So in terms of kind of the red flaggy questions, what are those things that you would be looking out for where you'd be going, actually this might not be a hip problem, it might be something else?
Yeah, that's a good question, and I think our first stage of assessment is always triaging for that, to see, are there red flags present? Your usual general health, weight loss, loss of appetite, do they have a history of cancer, particularly if it's a guy, testicular cancer, if it's a female, cervical cancer as well, looking at those. Avascular necrosis, have they been on steroids long term? Are they have alcohol or drug issues, that might make that more relevant in your mind. As you know, we look at runners as well, so this time of year I'm getting quite a few London and Brighton Marathon runners through the door, so stress fractures, do you suspect a stress fracture? What might lead you to that more if they put their program up too much? Are they your traditional tall, slim female? Do you have other reasons to believe that? Are they in the military? Are they doing lots of that kind of activity? So stress fractures is a big one as well. I think night pain, labral tears, labral issues will be quite irritable and they will present with night pain, but don't just assume that is the case. So your general kind of, are they having ongoing night pain, needs to be investigated if that's the case.
Okay, cool.
Yeah, and I think that's more relevant with physios working as primary care practitioners, where they're having access, and I believe you also involved in imaging. So I think that's one of the things we drive home very strongly on our course is, if you do suspect any like stress fracture, AVN or metastasis, don't be reassured by a simple X-ray, because most of them will have a normal X-ray.
Yeah.
So insist that to have an MRI, and give your reasons to your, suppose you're writing to, when I write to a GP, I say this patient had a previous history of cancer 15 years ago. The previous history of cancer is always a red flag, even if it's 40 years ago.
Yeah.
So if somebody comes with an unexplained hip pain who had cancer 20 years ago, for me, I'll always want the reassurance of an MRI to make sure that it's not a metastasis as well.
Yeah.
So it's having that sort of confidence in writing to GPs, because thankfully I never had any rejection, but it's putting that clearly in the letter to your GP. What exactly are you thinking? What's your thought process?
Yeah.
Because most people don't want to rush into an MRI, especially there's a lot of issues now in physio about anti-imaging. Don't rush to imaging, you'll find tears and things like that. Imaging does have a strong role, excellent for ruling out red flags, so that we can move on. What you don't want is in this age to rule out a pathology like an AVN and they end up with a hip replacement at the age of 32.
Yeah.
So is having that sort of strong suspicion, especially at this time of the year, a skinny female Caucasian comes with night pain.
Yeah.
You can always think of stress fracture as the first port of call, isn't it?
Yeah, definitely. I think it's having that, like you say, it's having that open mind to those things, which I think is key. Cool. And then just finally, I just had a question in terms of, so I'm assuming, and you guys tell me, but in terms of management, it's very much case by case, and you're looking really at you're looking at the whole picture, and then whatever condition it is, you're looking at how you can treat that with exercise, manual therapy, those sorts of things, in order to complement what their issues particularly are.
Yeah, I think the key things, the principles are going to be the same, whether it's a impingement or display. First thing is understanding the pathology well.
Yeah.
What are the AGs and how are they different? And respect the irritability. So obviously, if you got somebody with an impingement, giving them a break from aggravating activities like deep squats in the gym for a short period. And as physios, we can't really treat bone morphology. We go with an impairment based model.
Yeah.
So what's the impairments? Is a trunk. So a lot of times you're looking at the whole kinetic chain. So just not looking at the hip. Looking at the trunk impairments, because even a squat can be impaired massively by a restricted dorsiflexion. So all the sort of linking the impairments, because a lot of patients come to us and say, I've got this bump here, how can physio help? Which is a fair comment here. So I think the important thing to reassure the patient is, you had it since the age of 15 or 16, but you became only symptomatic at the age of 32, 34, because certain things have changed in your life. So we need to make that difference why they become symptomatic. So morphology is not pathology. So you need to have that sort of morphology plus loading factors plus personal factors. Then it becomes pathological, isn't it? People associate, I got like a big cam. I'm going to have osteoarthritis. So the biggest concern with most of the patients we try to readdress on day one is the big fear of getting arthritis. So nearly all of our patients, isn't it? We find that they are very worried that they're going to have hip osteoarthritis, and then they lead early replacement. So I think reassurance is huge, to assure them it's very common. So the stats we use of our patients are 1 in 4 patients will, general population will have hip impingement. 3 in 4 in the athletic population will have hip impingement. If you go to a big club like Arsenal or Chelsea, nearly 70 to 80% will have hip impingement. They're not going to all end up with needing surgery.
Yeah.
So I think it's very useful giving the sort of values here, reassuring them, de-threatening them, and understanding them, and that yes, at this point of time we don't have any level 1 evidence, but trying to change those variables, you can definitely get a good outcome. And I think from our own practice, I would say 70 to 80% of our patients are managed conservatively. We're definitely not anti-surgery. We work very closely with surgeons. Certain patients, like very elite, high professional sports people, they might not have the time for 3 to 2 months. They just want to get on with it. So even in the media, like Andy Murray, which is in the news, so those sort of high level patients, if you're a personal trainer, if you're a full-time yoga teacher, they don't want to just wait for 6 or 8 months on that. They may not be interested in the long term necessarily. So in that high active patients, we refer to our network of top hip surgeons we work with. So it's having that open mind, isn't it?
I think the key point, I mean, you mentioned it, Danny, as well, is the case-by-case approach. You can look in the literature and say that you should do a 12-week conservative management with everyone. Obviously, if someone comes through the door and they're 20, 23, 24, they've got a significant CAM, they're a semi-pro footballer, they've not been able to play for 18 months plus, then the chances of them being successful conservatively are slim, I would say. So it's having the knowledge of when you should fast track them for surgery, but I think also knowing which ones you'll do really well with as well. So if you've got someone a little bit older, does a bit of sport, they're willing to modify certain things, they're willing to have a rest for a while, they're willing to put the rehab in to strengthen the muscles around the hip and work on the way they move a little bit, then much more potential there. And certainly for me, where I've seen a lot more of my time being spent now is even with those that go for surgery, I think there's a very strong case for prehab, for getting them as good functionally and as good as in terms of strength as you can prior to any operations that they have. We know that the biggest prognostic factor of how well they do post-surgery is their pre-surgery functional levels. So I think that's an area that we're going to see grow more and more as well. Yes, if they do have to go down that route, have a good network, and we have different specialists that we refer to for dysplastic hips, for younger hip replacements, and for impingement patients, because they're all separate kind of skill sets in a way, but work in conjunction on the run up to that and do some really useful prehab. I think there's a massive argument for that.
That's a great point, because just like the knee for the ACL or anything, your pre-op function, hip is no different. So something which we offer in our clinic is giving like a 6 weeks prehab program specific for the hip, tailor-made, so that you try to reduce the deficits. So I like to say to a patient, like having a hip scope is like being knocked by a car. You're going to really go back. So if you're already at a good level, then your outcomes will be much better. If you're limping, you're crying, you're in night pain, you just can't barely walk, then rushing into surgery is not a good option. Control your pain, get back your function, and we got equipments like handle dynamometer, make it very objective. So people say, okay, let's try 6 to 8 weeks, get you in a good shape. And they really do well post-operatively. It's making that. Sometimes, obviously, we can't fix them with conservative, but at least they do well. And that's the same for the knee as well, isn't it?
Sure.
So get them at a good function, and I think there'll always be a role for physio there. It's not going to be all surgery. So there'll always be a subset of patients who will do well with conservative, and other patients we might have to prepare them for the surgical, both pre-op as well as post-op. So we don't see any conflict with that at all.
Perfect. Cool. And then any final thoughts from you guys, or any final things you wanted to mention about courses, or anything like that?
I think this year it's quite hectic, isn't it? So we're going for the last count we have sort of we got 10 countries confirmed. We start with Dubai. We're going to Spain, I think, in a week. Going to South Africa, Slovakia. I don't know why we're getting such exposure there. Australia and as well. So all of our course details are on the link functional fitness /courses. So I think the key, as a full-time clinician, we want to give a more practical based approach, make it relatable, and I love reading research and translating it, and not every therapist I can see loves, I spend like the weekends going through that sort of stuff. So what we're trying to do is make that sort of more relatable to a clinical point of view. And it's pretty much 70% is practical based, and since there are 2 tutors both of us, there's more one-to-one as well. So you're going to get more, supervision from that. And the big bonus, which I think which we give is we give them a lot of post-course reading as well. So you get a lot of material which you can assimilate as well. So I think when we first started about 6-7 years, we never expected to really. We've sort of covered more than 1,500 therapists over the last few years. So clearly the content. We like to think it's because of us, but but the fact is the content. We believe the content is the king. So we try to always work on that and keep it real, rather than be bogged down.
Yeah, I think our goal is to make complex issues simple. And if people can come on our course and then go back to work on the Monday and use it, then we've done our job. I've been on lots of courses myself in the past where the theory is fantastic. Lots of in-depth, lots of complex. And then you go back to clinic and you're like, okay, what was that? And you have to read it. Yeah. So that's our goal, isn't it? That people can actually, obviously they can digest it over months and months with the post-course reading, but their assessments and their hands-on stuff will change by Monday morning.
Yeah. Thanks, Chris, for having me.
That's all right. Well, thank you for your time.
Yeah, thanks.
Cheers, guys.
That was quite long, isn't it?